part 2 of our renal week. And let's start in on chapter 55. This is the, we're going to do kidney stones and bladder issues, UTIs and stuff like that. So let's start with urinary tract infections. Pretty common, especially in women. More common in women than men because women's urethra is a lot smaller than men's and in much closer proximity like to their anus, so when they're wiping, feces can tend to get up in there. So the thing with UTIs is prevention. You want to prevent somebody from getting a UTI. Urinary tract infections can lead to urosepsis, meaning sepsis caused by an infection in the urinary system, and it can kill, especially in the elderly. So you do need to be careful. Some people are just more prone to getting urinary tract infections, and there's some things they can do. Make sure that they're really well hydrated. Make sure that you train them to wipe properly, especially in women, that they should, after a bowel movement, wipe from front to back rather than back to front, because back to front then can spread E. coli up into the urethra. When possible, avoid indwelling catheters like Foley catheters, because when those are in, the incidence of infection is very high. So when possible, if somebody needs to be catheterized, you want to do intermittent straight cath instead of indwelling catheterizations. But the good news is if you can catch it early enough, and in the non-elderly, a classic symptom is burning with urination. So when the patient says that they're urinating, also they get the burning sensation. They probably have a UTI. They may or may not even have a fever. If it goes untreated long enough, they'll probably end up with a fever. But if you do a urinalysis, you'll usually find some white blood cells. It could be cloudy urine. Those are also indicative that the patient has a UTI, and the treatment of choice is Bactrim, and usually only need Bactrim for about 3 days. So you do want to prevent it. You don't really need to know about classifying them. Okay, it is important to empty the bladder, because when you get standing or residual urine in the bladder, that urine can then, bacteria can grow in there, because normally the bladder and urine is sterile, as you know, but when it sits in there and it's not excreted, it can start growing bacteria, which is why you want to try to completely empty the bladder when a patient is voiding. Okay, let's skip over to, that's really all you need to know about UTIs. Your book kind of goes on for a while. Pyelonephritis is now when you've got an infection up into the kidneys. Let's move over to incontinence. We're going to talk a little bit more about incontinence during the reproductive, when we talk about reproduction. There's a lot of causes of incontinence, stress incontinence, transient incontinence, things like that. But we'll talk about those more. Don't spend a whole lot of time reviewing that right now. Okay, what I do want to focus on is, let's scoot over now to chart 55.8, and what you would do if somebody starts having urinary incontinence. The problem is, when a person develops urinary incontinence, especially in the elderly, if a person sits in urine for a long time, it can cause a lot of skin breakdown, excoriation, perineal area can get infected. So there's a lot of problems just on the skin. If it is like stress incontinence, it can, and there's a bunch of commercials now about these women that they're dancing and stuff, which, because women who have weakened pelvic muscles, a lot of babies, any little thing that puts extra pressure on those pelvic muscles can cause stress incontinence. So if they're sneezing, laughing, jumping, things like that can cause stress incontinence. So there's a lot of things on the market now that women can wear, because it becomes a social issue if you're out and like all of a sudden wet their pants. So there are some things that you can teach your patient who is incontinent. And one is Kegel exercises. And the Kegel exercises, you've got the set of muscles down in the pelvic floor, and you just, Kegel's exercises is just to tighten and release and tighten and release. And you should practice this because you need to know what it is in order to teach your patients how to do this. So next time you are urinating, try to stop the urine stream and then start it again. Those are the same muscles, the Kegel exercises. And we teach our patients this following like transurethral resections, which we'll talk about during reproductive. Women who have had babies and cystoceles when like their bladder or their rectum is falling out through the pelvic floor, you can tighten those up, and it helps improve incontinence. Other things is like you would not, you don't give diuretics past 4 p.m. in the afternoon. If a patient has to have a diuretic, you would give it during the day so the patient can get up and get to the bathroom. You can do things like training the bladder. So, and I think your book, in this chart 55.8, where it talks about standardized voiding frequencies, you can start training a person like every couple hours to go to the bathroom. Prompted voiding, things like that, to try to try to teach the person when to go to the bathroom, strengthen the muscles so that they're not incontinent of urine. There are some medications that patients can use. You want to make sure that they're not overhydrated, but you don't want to dehydrate them either. And there are some other things. Like caffeine can make incontinence worse, carbonated beverages, alcohol, things that irritate the lining of the bladder. So sort of read through this chart, because it's good, because you need to teach your patients how to improve incontinence, because it's a huge problem, especially as people age and women who've had a lot of babies. So that's a really good nursing thing to know. Okay, so promoting urinary elimination. You always want to go with the rule that you want your patient to use the anatomy that God gave them. So if they, if the bladder holds urine and it empties through the ureter, that's the preferred method. However, there are some times when that doesn't work, and you have to use other kinds of means to evacuate the urine. For example, like suprapubic catheters that are inserted above the pubic bone. There are some urine stomas, urinary diversions. We'll talk about that in a little bit, to divert urine out through a stoma. I do want you to kind of know about some other different urinary diversion methods if incontinence needs to be treated surgically, or there's some kind of an anatomical restructuring that needs to occur. When a patient does have to be catheterized, and there are cases where, especially like after a woman has had a baby, if there's been pelvic trauma, sometimes everything, like the bladder will fill up, the person will feel like they have to urinate, but they can't actually initiate the stream. And you don't want that bladder to get too distended. You don't want the bladder to rupture, so you have to catheterize. And straight cath is, intermittent straight cath is the treatment of choice. The next page, 1588, shows you kind of what a suprapubic catheter looks like, compared to like the indwelling catheters or intermittent catheters. I would recommend that you, I do want you to know chart 5510 on page 1589. The problem with indwelling catheters is the high risk of infection. I think I read a study one time that said something about 100% of patients who have Foley catheters in place will have bacteria by day 3. So, I mean, it's crazy high, you know, the infection rate. But in addition to that, they can develop bladder stones, they can develop sepsis. So when your patient does have a Foley in, you need to have very astute nursing care to make sure that you're maintaining sterile technique, you're doing really good perianal care, keeping a good assessment on the urine in the bag, and watching for if the urine becomes cloudy, it's probably, you know, infected. And the elderly patients are not going to have the same symptoms of infection as younger people. So they might not develop a fever right away. They might not develop you know, pain with urination and stuff like that. So, you know, you have to watch for other signs and symptoms, which could be in the elderly, mental status changes, lethargy, you know, things like that. Okay. Once a person has a catheter in place, the muscles of the bladder start atrophying, and they decondition is the word I was looking for. They decondition pretty quickly. Just like if you don't lift weights, your muscles start become atrophying. So when you put and this is the same concept as when somebody's on a ventilator, their pulmonary muscles aren't working as well. So the muscles in the bladder, if there's a catheter just draining it all the time, that bladder never fills, it doesn't stretch, it doesn't retract to relieve the urine. So when it comes time to take the catheter out, oftentimes that bladder is deconditioned. So sometimes you need to recondition the bladder before you take, before you just, you know, let somebody go off to the wind. So if somebody has had a catheter, indwelling catheter for a long time, you might have to retrain the bladder. And you can do that with you know, like you'll take the Foley catheter out, and then you might have to intermittently straight cath for the next couple days, every 3 to 4 hours while the bladder is retraining itself. Sometimes, you know, after surgery, after babies, and this needs to, you know, when you're intermittent straight cath, you need to maintain sterile technique because you don't want to also introduce more bacteria. So anyways, once you take the Foley catheter out, you do have to document and make sure that the patient is able to void on their own within, you know, 2, 3, 4 hours, just to document that that's all working. Okay, so that's it with bladder and catheter, that kind of stuff. Most of that should be fairly familiar. Now I want to talk about kidney stones and bladder stones. Bladder stones are called urolithiasis. Kidney stones are called nephrolithiasis. Lithiasis being the word for stone, the medical word for stone. Sometimes stones can develop in the renal system, and it's very painful. We're going to talk a little bit about the medical management and what to do about it. There are 4 different kinds of stones: calcium-containing stones, uric acid, oxalate stones, and cystine stones. Those are the 4 kinds. When a patient starts developing stones, and they can develop them for a variety of reasons. Cystine stones tend to have a genetic component to them. Calcium stones, you know, are from calcium. As with oxalate and uric acid. Usually the patient who's developing nephrolithiasis will complain of flank pain. And by flank pain, I mean, like, you know, right back here on the, just below the ribs. That's flank pain. And it can be extremely painful. If the stone is small enough, you just let the patient pass the stone. And you treat them with pain medications because it is so painful. They say it's equivalent to childbirth. So you do want to help the patient pass the stone. You also give them a little screen thing so they can pee through a screen, because you want to catch the stone, because you want to find out what kind of stone it is, because the treatments are, slightly different. But if the stone is too large and can't pass, and so you kind of have to watch the person, you got to be a little bit careful, because if it doesn't pass, it can get lodged in there, and then it can cause some infections and pyelonephritis and some other issues if it starts getting backed up. So the key with kidney stones is you want to prevent them. If somebody has had a kidney stone, and by kidney I mean nephrolithiasis or urolithiasis, stones in the renal system, once, they are much more likely to have it again. So you want to prevent the recurrence of stones. And the chart 5512 on page 1592 of your book is excellent for that. In the past, people who were passing kidney stones, we were taught that you give them lots of water because you wanted to flush the stone out. Well, we don't do that anymore, because sometimes the stone can't get flushed out, and then everything backs up, and then your patient's just fluid overloaded, and they can't get it out. And then, so now we don't force fluids on somebody who's passing a kidney stone. What you do now is just, regular fluid stuff, and then once you find out what kind of stone it is, most of the stones are calcium stones. That's the most common. And we used to think that if you had a calcium stone, that you needed to avoid calcium. The problem with that is that studies have shown that that doesn't really help prevent recurrence, but it did lead to osteoporosis, especially in women, because of the reduction in calcium. So if they had a calcium stone, we still let them have calcium-containing foods. However, that's not the case with the other three, with uric acid, cysteine, and oxalate. With those kinds of stones, like an oxalate stone, you do need to be careful that they're not eating foods that are high in oxalate. Things like spinach, strawberries, rhubarb, tea. I drink a ton of tea, but peanuts, those kind of things that have oxalate in them. Cysteine stones, like I said, is some people have like this cystinuria, which is like a genetic thing. But in all cases, after they've passed the stone, then you want to start hydrating them. You want them to drink lots and lots of water after they've passed the stone. You want to tell them to avoid getting dehydrated. They're more likely to get a stone if they're in hot climates. Things like that. You can read the how to prevent the kidney stones there. So then once you know that somebody has a kidney stone, if it is too big to pass on its own, like it can't get through the ureters and the urethra, then there are some other options for removing that stone. You can't just leave the stone there, because it will lead to infection and cause a lot of other problems. So there are things called lithotripsy, extracorporeal shock wave lithotripsy. It's like using sound waves to sort of break up the stone. So if the stone is big, they use lithotripsy, which is they can do it percutaneously, like through the skin. They can do it transurethral, where they will go up through the urethra right to the stone and send shock waves next to the stone, and the stone can break up into little pieces. Sometimes they have to go in surgically and retrieve the stone. And in worst case scenarios, if they get big stones that get stuck up in the calyx of the kidney, they have to go in and operate. But that's really rare that they actually have to go in and operate. I think, Yeah, on page 1594, they kind of show you some of the different ways that stones can be removed. Now, if they go in and surgically remove it, or they go up through the urethra and pull it out, like in figure A up at the top where they pull it out, you will expect that there will be some, maybe some bleeding afterwards. That's okay. As long as it's not like bright red hemorrhaging blood, that's okay. But anytime they go through the urethra, there might be a little bit of trauma. You might have a little bit of bleeding, serosanguinous, but that's okay. In the case of when they do lithotripsy, where they use shock waves to break up that stone, now you want to increase fluids because you want to help flush out that. Now instead of having a stone, now you've got like sludge and sand, and you want that to pass through the ureters. And you watch it very closely. You want to make sure that they're having good urine output because you want all those stones and all the pieces of stone to come out. Because now you're trying to prevent infection and obstruction of the urinary tract is the big thing you do following lithotripsy. So once your patient has had a stone, educate them about the possible cause of the stones and ways to prevent future stones from developing. And they need to be very well hydrated. Okay, that's kind of about it for stones. Bladder cancer, not one of the more common cancers. It's not. You're not going to see this a lot. Smoking is the leading cause of bladder cancer, and their treatment is pretty good. However, and they can do some bladder preserving surgeries, especially if they find the cancer early. But even if they get in there and find out that the cancer is in the entire bladder, they can take the whole bladder out and just do an ileal conduit. Which I think, on page 1599 where it talks about urinary diversions, there's a bunch of different ways you can take the bladder out and just divert the ureters out either through the skin, or they've got a couple different ways where they can put it into the colon or make a pouch or something like that. On page 1600 they show you some of the different techniques, how they divert the ureters if they have to take the bladder out, and sometimes they can make little pouches. They can do like a Coke pouch or an Indiana pouch. And then the thing that you watch for as a nurse is now they'll have a stoma. So kind of like a colostomy, this will be a urostomy where they bring a piece of the ureter up through the skin, and then your job is as a nurse is to make sure that stoma is nice and pink and red. It should not be purple. It should not be crusty. You want the skin around it to be nice and smooth. Google image some, pretty looking stomas so you know what it is. Because if it gets purple or black, it could be necrotic. It could be getting encapsulated and getting ischemic there. So those are some things you need to watch for. The other thing, once somebody's had an ileal diversion where the ureters now are going out of the skin, it's an awful lot of psychosocial issues, because it's really hard on somebody who used to urinate through their urethra, and now the urine is coming through a bag in their stomach. So there's a lot of work that goes into helping somebody learn how to take care of their own stoma. When they first come out of surgery, first you're going to do a lot of prep work ahead of time. Get the wound nurses involved so they can find out where exactly to put the stoma, because you don't want to put it on a belt line, and it matters because sexual issues come into play, so it matters where the stoma is, and it matters a person's ability and their family members to accept this stoma. So you start teaching them ahead of time, and then in the immediate post-operative phase, it's okay to tell them that the nurses will take care of the stoma. Like, okay, Mr. Smith, we're going to go in for surgery. We're not going to make you take care of this, right away. The nurses are competent. We can take care of it for you. And while we're taking care of it, we can start showing you how to take care of it at home. And it might take a while, depending on the person's level of comfort with these kinds of things. So give them some time to accept the stoma, and talk to them about it. But there's a lot of preoperative, postoperative care that goes into giving somebody a new stoma. And that's true with colostomies, urostomies, nobody wants to have an ostomy of some kind. So anyways, that's about it with the conduits. And that's it. That's all you need to know for this section. Yeah, so that was not bad. Okay, that's it for this week. See ya.